To week 2 of the Spotlight series on partnering with different demographics in research. My name is Agustina Gancia, and I lead the capacity building program at Health Translation SA. I'll introduce all of that in a few slides, but I'm welcoming you and opening up the session. And before we officially begin, I would just like to acknowledge the Ghana people as the traditional custodians of the Adelaide region. We recognize the Ghana people's cultural, spiritual, physical, and emotional connection with their land. We honor and pay our respects to Ghana elders, past and present, and all generations of Ghana people now and into the future. So today's webinar is part of the Spotlight series. And what this initiative is, it's a capacity building program where we explore at each series a different topic around research translation. We've explored 9 different topics up to date, including implementation science, community engagement, research impact, patient-reported measures, health economics, and many more. You can see them at the bottom of the slide there. If you'd like to access these, any of these topics, they all live on our website, on the HTSA website. So all of the previous webinars live there, and all of the previous resources that we've shared relating to these topics live on the website as well. And so will today's webinar after we finish recording the session. It really is made for people to explore a topic around research translation and learn about these topics in ways that how have people done this topic? So how have people done engagement in research? How have people done implementation science? So we hear examples and case studies. And who's Health Translation SA? Just a quick introduction, because some of you might come in. This might be your first interaction with HTSA. We are South Australia's statewide accredited research translation center. So we've been accredited by the NHMRC, the National Health and Medical Research Council. And what our role is to act as a catalyst and a broker to mobilize collaborations within South Australia. We aim to improve health outcomes through research translation. And what that means is that we want research to be applied into policy and practice. So we want that to be accelerated and done well. And we have 3 key priorities. And the one that is relevant to us today is empowering the people. So that's building people's capacity to properly translate research into practice. And part of that is actually engaging with the communities that benefit from the research that is produced in South Australia. And so that's how where this fits in. We have, because we're South Australia's only translation center, we have a wide range of partner institutions, including SAMRI, which is where we're based, the universities, Flinders, Uni Adelaide, Uni SA, and Torrens, the PHNs, which are the primary health networks, the Commission on Excellence and Innovation in Health, and the Aboriginal Health Research Council. This series explores the topic of CCI, consumer and community involvement, deeper than the series that we have already done in 2023. We delve into partnering with different demographics. And this week, we're delving into engaging people with disabilities and who are frail, homebound, and bedridden. Next week, we explore engaging with people who are culturally and linguistically diverse, so multicultural communities. And the last week of the series, we'll delve into engaging with youth. And these topics actually have been brought to us at the request of researchers and consumers who wanted to learn more. So today's speakers, we have a great lineup of people presenting today. We have Dr. Maria Alejandra Pinero de Plaza from Flinders University and Penelope McMillan, who is a consumer partner on many projects, including with HTSA and with Maria Alejandra's program of work. And we also have Melinda Brown, who's an inclusion advisor from SACID. So I'll quickly introduce them, and then I'll hand over to Maria and Penelope. So Maria Alejandra is a research fellow at Flinders University, and she specializes in health service research, focusing on advancing public health through innovative research and implementation science. Um, and her body of work aims to enhance the efficacy of health interventions and to utilize technology and behavioral science to improve the quality and accessibility of care. Penelope, who will be presenting alongside her, brings lived experience of multiple disabling chronic illnesses to her voluntary advocacy work in the topics of aging, caring, disability, chronic illness, and MECFS. And part of this work involves collaborating with research to develop, implement, publish, and disseminate studies that inform innovation. And finally, we have Melinda, who's joining us. She's a passionate self-advocate from South Australia. She likes to speak up for the rights of people with disability and does that through the many groups that she's involved in. As mentioned before, she's an inclusion advisor at SACID, and she's a peer mentor as well for Our Voice SA, where she runs peer groups. So on that note, I will stop sharing my slides and hand over to Maria and Penelope. Thank you.
Thank you. Thank you. All right. Can you see my slides?
Yes.
Okay, so thank you for that kind introduction, Agustina. So as you mentioned, we are talking about partnering with frail, homebound, and bedridden people. And I'm going to start with also, wait a second, let me see how this progresses. Here. Okay, I would like to acknowledge as well, we would like to acknowledge the Ghana people, and we pay our respect to their elders, past, present, and emerging generations. And I'm sharing a co-design, actually, study that we developed with a group of them. So the table of contents, we are going to talk about the academic need that generated this process of engagement, and then the community need that we found out after researching about how can we investigate frail, homebound, and bedridden people, the evidence on consumer engagement, we review the evidence, the designing and co-designing process of this study, the knowledge translation engagement theories that we use and how we use them, the outputs and outcomes of this process, and the takeaways, and later the questions. So first, I mentioned the academic needs. So this work started because I was employed to evaluate a video on frailty. And this video was produced between the Center of Research Excellence in Frailty and Healthy Aging of Adelaide Uni and the knowledge translation program of Flinders University. And the idea was to promote the effective transfer of research findings in the area of frailty. But that met with my previous experience as a consumer advocate and a strong interest that I brought in engaging stakeholders as co-researchers. And this came from my experience of almost 3 years with the SAMRI Consumer and Community Engagement Group, where you can see there also Penelope. So and we were working together as consumers, both of us. So then with that task, I went back to my community connections, Penelope, and she will tell you about this experience. And she brought something very important, that the frail people also embedded, the concept of frailty also embedded issues with invisibility of people that were homebound, they couldn't leave their home because they needed assistance, their marginalization, and the health quality of life deterioration. And this was all triggered by a report that the Ricky Buchanan that we see at your left created. And she has been very vocal about this. And well, the report was, to me, shocking. And it was shocking as well, the gap in research. There was no evidence of research here in Australia around that. Few interviews. So Penelope joined me into merging this with the video evaluation and trying to investigate this. And well, here we are highlighting some statistics from 2018, meaning that after COVID and considering all the group of people that could be homebound for many reasons, we assume that more than 500,000 Australians now are homebound. And around the main issues, I think Penelope is going to talk about that.
Yeah, so Ricky's report is called Just Invisible, and it's primarily talking about how people who are homebound are invisible to the health system. So if you even to get telehealth, first of all, you have to get access to telehealth through turning up face to face to a general practice at least once a year. So if you're homebound or bedridden and are not able to go out and visit a general practitioner, then you can't have telehealth. You are locked out of primary health care. And the other factor that plays into that is that a lot of people who are homebound live in poverty because they're often not engaged in paid employment, and sometimes their family carers have to reduce their paid employment to care for the person who is homebound. In the small print at the bottom, in the UK, the NICE guidelines for MECFS say service providers should be proactive and flexible in delivering services, including home visits, online or phone consultations, and supplying written communication. In the US, the CDC says these patients who cannot make office visits due to the severity of their symptoms require in-home assistance and phone and online checkups. So that's what people in the UK and the US, this is what the clinicians are advised to do. But in Australia, the Medicare system doesn't subsidise those things. So people who are homebound, and it doesn't matter why you're homebound, it could be for a severe psychiatric condition, it could be physical disability. People are homebound also for sociocultural reasons. Access to general practice. People who are homebound need access to telehealth without the qualifying annual face-to-face GP consultation. And we've asked and asked and asked for it, and it's not forthcoming. We need GP clinics to be able to financially support home visits by their GPs and practice nurses. We had one person who is homebound. She desperately needed to get medical care, and volunteers phoned 75 local GP clinics and could not find a single GP willing to make a home visit so that she could then get telehealth because the Medicare system doesn't make it financially viable. And then with allied health, you can't get Medicare subsidies for allied health unless you get a referral from a GP. And you also can't get referrals to specialists. Anyone you see, you will have to fund 100% yourself unless you've physically seen a GP in the last 12 months, with rare exceptions that are about to be introduced. But homebound people don't figure in those exceptions. So if we had home visits, if we had access to telehealth, then you've got the potential to slow or to reverse people's deterioration. And you've got potential savings not just in the health system, but in welfare, with income support, and with disability services. But none of those things will occur without academic evidence to lend weight to political support and get support from the Department of Health and Aged Care. I just want to say one thing about evidence, Alejandra, before we move on. So I'm taking a little side issue here. If your research does not include the sort of groups that this Spotlight series is talking about, if your research doesn't include us, then you don't have evidence about that applies to us. And with no evidence, the clinical guidelines, the evidence in those that drives those clinical guidelines don't really apply to us. The NDIS, there's been a big drama because the NDIS is saying we will only support evidence-based therapies. But who's doing the research on people with disabilities to see which therapies have an evidence base? People are saying this helps me a lot, and the NDIS says, yeah, but there's no evidence. Please, 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 all these groups from the Spotlight series, not just frail, homebound and bedridden people, if you're a researcher, we need to be part of your research. And if you're a consumer like me, you need to harass those researchers to get them to include us.
Yes.
Now
So
I'm going
using
back to you, Alejandra.
that's okay. So using these principles, Penelope and I were working, like I mentioned, in consumer engagement with health research, and participated and co-authored our study on consumer engagement with health research and its impact in policies, etc. So what we knew from our consumer experience perspective is that engagement wasn't clear. What we see in the literature is that is poorly explained. There is a lack of involvement, so consumers tend to be involved at the end of the study. There is a lot of what they call tokenistic involvement, so just to tick boxes and say, yes, we had them. And then we needed methods and ways to engage consumers. So what we found in the systematic literature review is that these are the strategies that we have listed here: interviews, focus group, workshop, advisory groups, co-design, surveys, storytelling, etc., dialogue. And the enablers of these were early and sustained involvement, trust, and clear roles for consumers and researchers and any other stakeholder, support, training, flexibility, institutional backing, so important, and feedback loops. This is not something that happens once, it happens across the study. So with that in mind, and considering all the problems that we saw, we kept researching now with the community, and here Penelope will tell you a little bit more about it.
Yeah, so one of the problems for a lot of researchers is they go, well, you want me to have a diverse cohort in my research. How on earth do I find these people? With frail, homebound, and bedridden people, this notion of being invisible in the community is very real. You may be living next door to someone who's homebound, you wouldn't even know. So you can look at existing databases of consumers who are interested in engaging in research. So Health Translation SA has a consumer engagement database. COTA you heard about last week. You can go to community organisations for chronic illnesses or for mental health. You can go approach social media networks. And when you have a networked contact, like in Alejandra's case, that's me. I'm networked with people who are frail, homebound, and bedridden. Use those contacts for outreach. So social media conversations, newsletters, seminars, you can rely on consumers in the community to do that for you. The thing is, there are special needs for access and inclusion that are different for different groups. For people who are frail, homebound, and bedridden, video calls, email, shared documents, telephone, hard copies. You need to use the communication modes that the individual is using. And the timing and commitment, you need to check what works for the individual. And if in-person contact is needed, you need to arrange funding and protocols for home visits. And I just want to bring up one particular example. At SAMRI, they had a study, they wanted blood samples. And they included in the grant application funding to make home visits to anyone who lived within 40 minutes of SAMRI, which is a lot of people. And the funding was given. If you need funding for special access considerations, ask for it in your grants. And there's a very good chance you'll be given it because it's a really good reason to ask for extra money.
So as you saw from the beginning, I mentioned that I was employed to evaluate a frailty video. But after consultation with the community, visiting people, activating the networks and connections, we realized that this is a topic by itself, separate from that project. So we co-designed a study and thought about, okay, what are the stakeholders that we need to engage? What is the power? We decided to use what is called participatory action research, which is a collaborative research approach where those affected by a problem actively participate in the research process, from defining the problem to implementing solutions. So we reach out, like Penelope was mentioning, to MECFS Australia. We got letters of support for them from ME groups, from MECFS Australia. We communicated through Teams, etc. And this is kind of a general view of what was our process of working together. And we got a grant, an accelerator grant of $4,000 from the Caring Futures Institute in order to promote what happened. So this is a short video, but I won't play it out. It's a short video describing how we did this process at the sketching of working with our peers. So then, because I was employed in knowledge translation, we went back to the literature, and I was working under Professor Alison Kitson, who developed this model to the left that is called the knowledge translation complexity network model. This model, we decided to use it because it gave us a perspective, a macro perspective, and in fact, using this model made us to become into a program of research, because we had to understand what the community needed, what health providers needed, what the government needed, what education and research needed, and in which stage of the research process. You see at the left, problem identification, implementation, knowledge creation, evaluation, knowledge synthesis. This is the process of research of any project, but the problem is normally in the past, people used to think, oh, this is linear. So we identify the need and we do this. But if you realize that you have all these stakeholders working together, you know that the state of the problem is different. Maybe they are at the implementation without the synthesis of knowledge, etc. So we use this. To personalize the information, we use this body map technique, thinking about what the person feels, what they enjoy, what they take away from the work that we do, what they don't like. And for the process of engagement, the whole process now across the program, we use this model that is called the Learning, Evaluation, and Planning Framework from Evaluation Scotland, that takes participatory research projects across 5 steps to understand and benchmark and go through this loop of research where we know, we benchmark, we assess what we did, and we keep going. So that was our process. How did we implement this? Like I said, it was a program. When it's a program means that you have a big, broad area and you have several projects below it. So with the knowledge translation complexity network model, like I explained, we map out the needs of our different stakeholders to understand how the engagement and the research was going to progress. With the LEAP, the learning, evaluation, and planning framework, we implemented the procedures and constantly assess what kind of project, what kind of research we should do for this sector. With co-design and art-based methods, we use the body map for storytelling, generating. We use surveys to collect data, and then use the life experiences of all these people to kind of communicate the message that was about highlighting this need, bringing light to this problem. We use a hybrid model where we blend traditional research outputs with outputs that were mostly for the community and for awareness. And the integration of all 4 things end up being a method. So the way that we create this, develop a strategy, and we decided to publish a route about it. So we created what is called Proliferate, and eventually across different, working with different stakeholders, it became Proliferate AI, which help us to evaluate innovations with participatory research models, even using as well artificial intelligence. But this was all well and nice and fine, and it reached a lot of people in terms of their emotions. But as Penelope was saying, we needed evidence, scientific evidence that will support what we are saying in terms of we need telehealth, we need these services, these people are excluded and marginalized. So we decided to start systematic reviews and meta-analysis to bring this evidence.
So I want to talk just briefly all the different aspects of research that Alejandra's just described, whether it's a systematic review, whether it's knowledge translation, whether it's an academic publication or developing a video. What sort of roles are realistic for people who are frail, homebound, and bedridden? Well, the fact is, pretty much anything. So the different research types you might involve us in include benchtop, clinical trials, surveys, systematic reviews, participatory knowledge development, program evaluation, and the roles that different individuals from this community can play include being a participant, and very often we're left out of participation in studies, but we can be participants, we can be a consumer with lived experience, we can be a consumer representative who claims to have networks that allow them to represent views of other people, not just themselves. You can be a consumer expert, someone who's familiar with the literature as well as consumer experience. You can be a co-author, you can be an investigator, or even a co-chief investigator. So you're not limited in how you can use people like me.
Yes. So working with them, we got several outputs. And again, remember, we became a research program. So then you will see how each sector got their outputs and outcomes. So in terms of health systems transformation, remember that I said that we needed the evidence. So in 2023, we published with JBI Evidence Synthesis the protocol of why this is a gap in the knowledge. Why? How can we research this? Then we published in many conferences, in many book chapters, and Penelope by herself, me, both together in different areas about how we need to transform the health system to embed homebound people. We also trigger investigations around using big data and how that work out. And just 10 days ago, we published finally the systematic review and meta-analysis that actually confirm that telehealth is a care solution for homebound people. It reduces hospital admissions, it improves quality of life, it improves well-being. So, and then all this process, it took us like from 2023 that we published the review, 2025 that we published, the protocol, and then 2025 we published a review. It took us a lot of years, and in the process we informed a successful NHMRC grant application about safe at home using technology to support people with chronic diseases at home. So in terms of policy impact, this was incredible because our storytelling techniques of engagement, the pictures that we got from consumers, we created a gallery with videos and posters that people can actually download and use it and paste it to promote their engagement. And we were disseminated during COVID as the evidence around COVID-19 and the use of telehealth for people that were homebound. We have been cited in submissions to the Royal Commission. We created a submission to the Royal Commission. We changed, in fact, the Queensland government techniques to approach homebound people. So this was incredible in terms of policy and impact, and we are hoping that our review will help us change policy. Then in terms of consumer-led and consumer-oriented examples, we created a video, and we are hoping to play it. It's 2 minutes 20. And it was a winner of the Consumer Health Forum with ideas. It gave us awards, research awards. We produce reports about the issue, but this is a summary of what we did with the consumers, separate from the systematic review. Let me see if I can share this. Sorry.
Yeah, we're not
I
getting
don't think we
that.
can hear the sound.
Okay, so that's okay. I think people can access through with the QR code, but this was a nice summary of what consumers said it feels to be a homebound person. In terms of knowledge translation, as we were talking about, that we created this methodology of engagement, working together, evaluating our results, our outputs, and also contributed to other research programs with our examples of homeboundness. So we got a lot of prizes. We published in 2023, the methodology called Proliferate is this paper in Health Service Research Frontiers. And recently, because of this method, we attracted other people that wanted to apply this methodology to evaluate and assess and transform their research. We just published in 2025 the use of Proliferate AI to evaluate the implementation of an artificial intelligence in emergency departments. The results of that process is a lot of awards and prizes because of the innovation. So what was the main message with this is that the creativity, the identification of the real need that only comes from people with lived experiences generate all these fantastic outputs for every sector of the program.
And so my concluding remark is that remember the power of social networks. The only reason any of this existed, and a lot of it is innovative, a lot of it is making quite a big impact. We haven't changed the government's Medicare benefit schedule yet, but that's next on our list, is that, the Just Invisible report, I had been sending that to politicians and journalists and talking about it to anyone who I thought would have the slightest interest, because it was so powerful in explaining what the problem was for people who had no access to the health system except by ambulance to hospital, where they're not set up to deal with primary health care. And then Alejandra and I, as Alejandra indicated at the beginning, we had known each other through consumer engagement for quite a long time. And I was sitting next to Alejandra in the SAMRI building and at an event. And I said, hey, this homebound report. Anyway, I sent it to Alejandra. She paid attention to it. Next thing you know, she's got her Alison Kitson involved, Flinders University, the Caring Futures Institute. Everything you've seen this morning came about through this casual network. And it's really, really important, whether you're a researcher or consumer, to make the most of the people you know, and then through them, the people that they know. And that's how this really, really important area of work that's been ignored internationally, that's how it came into being.
Yes. So to finalize, just basically what we could say is the co-design with lived experience is very important. Our experience with storytelling was fantastic. Stakeholders, collaboration delivers, and we created the method that we talk about, and now we are changing systems as a product of this, with even digital systems, with our methodology for engagement and evaluation, Proliferate AI. Thank you. You're muted.
Sorry, yeah. I just noticed I was on mute. Thank you so much, Maria and Penelope. That was a fantastic and very thorough presentation. And I guess it really demonstrated the impact that you can have by doing engagement, and you really demonstrated the impact in the different sectors, so at different levels, what can come about from proper engagement and proper inclusion. So it was fantastic to see. We're going to take questions at the end of the presentation, so if anyone has questions or comments, please put them in the Q&A or the chat so that we can then address them at the end after Melinda's presentation. So what I'll do now is I'll share my screen and Melinda will then take the mic. And here we go. Let me just share what I have. It's opening. Give me a minute. There we go. There we go. So, Melinda, over to you.
All right, you can change. Oh, yeah.
Yeah, that's it.
Okay. Hi, my name's Melinda. Brown. I am joined from Garnet Land and pay my respects to the owners of this land. I am a inclusion advisor at SACID. SACID is the South Australian Council Intellectual Disability. We are the peak of body of people with intellectual disability in South Australia. I am a self-advocate and share my lived experiences in training and projects at SACID.
Next slide.
Next slide. So everyone is different. People with intellectual disability might need support in areas like communication, how they speak, or how much time they need to express themselves. Organisation, how they book appointments or plan their day to daily life. Socialising, how they build relationships or meeting new people. Themselves, self-care, how they look after themselves. When you do research with people with intellectual disability, it is important to listen. Listen to how people want to work with you. For example, some people might write things down or draw instead of talking.
Next slide.
Next slide. I have helped researchers work with people with intellectual disability. Here are some tips from my experience. Have a meet and greet with your code designer or code researcher so you can get to know the person. This person is a chance to ask questions. You can talk about how each of you like to work. Meeting as early as possible. You want to live with lived experience on the project as early as you can. And co-design can take longer, so you might need more time to meet your deadline. Next slide. It is important for me to understand what your project is so I can explain it to the other people in a consultation. I can use my own words to explain it to other people. Tell me why you are doing the research. It is important to know how our information is going to be used. We want to know, is it being used for a form, research, or for numbers, reports, or something else? We can sometimes feel like people take our experiences and we never hear anything again. Please make sure to share what you make with at the end of your project. We are the experts in our own lives. Some ways that you can value our experience are having a person with lived experiences to present consultations. This is a good things to do because people might be more comfortable to share their stories with me. And you can take notes while I lead. You can also ask questions if you want to. Just quick. That's okay. I can help you make information more accessible. I can lay documents into easy read or give you feedback about pictures or visual aids. Involve me in writing your final report or understand your findings. I might have insights about things that help to explain what you have heard in your research. Next slide. It is a human right to have information that you can understand. So it is important that all your information is accessible for the people with intellectual disability. Everyone is different. Ask how people want to get information from you. These are the few ways I like to get information so it is more accessible for me. Use pictures or visual aids. This would include using faces or emojis. If you have scales, questions like the pain scales or scores of 1 to 10. Yes or no boxes can make some things easier. Use thumbs up or thumbs down as a visual aid. Use easy read or plain English. Easy read is preferred. It uses every word to make things easier to understand. It uses pictures with a few words so that people can connect to the writing. Send information in advance at least 1 week before. This could be focus groups, questions, or agenda. I prefer to have at least 1 week to prepare and think of my ideas.
Next slide.
Next slide. Here are some ways you can make your consultations more inclusive. Introduce everyone, including people who might not have a talking role in the meeting. It is important for everyone to feel comfortable and know who is there. Use icebreakers. Icebreakers could include questions of the day, like, what is your favourite ice cream flavour? Use traffic light cards. Like, green means I agreed. Good, yes, great idea. Yellow means I have a question. I have an idea. I want to say something. I need more time. The red one is I'm not sure. I do not know. Slow down. Can you say it again? I do not agree. I do not want to understand. I do not understand. They help people who find it hard to talk in meetings. A green card I just explained it. Okay. You can use thumbs up or reaction if meetings online. Do not rush. Make sure you take your time and give everyone a chance to think and say things. Next slide. Thank you for listening to my tips. In my work as SACID, I help organisations and researchers to be more inclusive of people with intellectual disability. Here are some of the things we do. We help people to run consultations for their research. We partner on projects and run co-design groups. We make and test easy read information. We run a lot of trainings for professionals. Our trainings include intellectual disability awareness, inclusive practice, co-design, developmenting, easy read, and supporting decision making. You can contact us by email, phone, or website. Next slide. Thank you for listening to my presentation. Thank you.
Thank you so much, Melinda. That was great, and it was full of fantastic tips in there. I loved the use of the traffic light cards. I think that was I think that was great. I would like to ask the audience now if they have any questions. I see there is some already some comments in the Q&A and the chat function. Someone asked about to ask to the team, Maria, Alejandra, and Penelope's relating to their presentation. Do you have any GPs or any of your projects as partners? And so they answered, yeah, would you mind answering that so that people who haven't read the chat can know a bit more about your answer?
So we could have different answers. In general, for the whole program, we work with medical doctors and also nurses, practitioners, no GPs. However, Penelope might have additional information about the people that she has contacted through her lived experience.
Well, I think to start with, it's actually important to know that the team that has gathered around this now quite large and complex body of work includes people from multiple clinical backgrounds, so that moving forward currently, I mean, there are people from allied health and from nursing and from other specialists and so on who are engaged in either specific projects or with the larger team that is always there in the background contributing to everything we do. So the clinical side is part of the team. And then from there, you're really looking at the consumers to bring from their personal clinicians what the challenges are in clinical applications, what their doctors and nurses and allied health practitioners are struggling with, where they find, because when you're a patient, I don't think it matters what your background is as a patient. If, like me, you're able to engage with the health system, you get your doctor saying, oh, I can see you've got a problem with that, but I've got no idea what to do about it. That sort of thing. And then you go, oh, well, I could bring that to the research team. We got a problem, right? That needs a problem, a practical problem. That's what health translation SA is about. Let's fix some of these practical problems in the health system. So, yeah. So there's no clinical partners out in the health system, but inside the team.
Okay.
That's a fair statement, isn't it, Alejandra?
Yeah, so we have clinical partners and networks, people working in hospitals, etc., and allied health, as you mentioned. However, the GP, exactly a GP, we didn't engage personally directly with one GP through our networks. Yes, and yeah, well, GPs are so busy, and many of them claim being underpaid, so it's difficult again to involve them in this kind of work that is basically volunteering sometimes.
Thank you. I see someone else had a comment around having collaborated with SACID for developing easy read guidelines, easy read guides to improve the accessibility of their resources. And Sarah said it was fantastic. So thanks to SACID for that. Melinda, would you have any I guess, tips for anyone wanting to learn more about easy read guides?
Come and join our easy read trainings. Sometimes I might be presenting them. We do let them to do their own activity as well, like a homework kind of thing, and we do test it for them as well. We
Fantastic.
also do just testing as well.
Yeah.
So if they want to try to make their own, we can invoice. I don't know how to do it in the invoices. I don't know.
They can just call the office.
But they can call it the office,
Yeah,
or on our website. So
it's fantastic. Thanks, Melinda. And I have another question for you, a short one. Someone from the audience asks, how did you get involved as an advocate with SACID?
how? Well, I went to the conferences, and that's my journey started. And then I started at PCRU, and then I actually got employed, and I just gone from there.
Fantastic. Well, I see you're doing some great work. I see some other comments in the chat and Q&A about a few topics going on in the chat, and I'll leave them in the chat and for people to read. One is about nutritional guidelines and how they're important, and then particularly one that I agree with is warmth and active listening actually break the ice. So that's an important, I guess, consideration when we're engaging with the community, different communities. It's really active listening and genuinely, I guess, applying what we hear, and applying it to the research that we're doing.
I have a comment.
Yes,
I have a comment, if I might. Linking to things like Easy Read and the tips that Melinda gave about, if you're in a room and you're talking with people with intellectual disability, one really important aspect, which is Alejandra alluded to it, but it wasn't highlighted super especially, is that in our work, we make sure that it's not just all about words.
Yeah.
Right? So in our very first survey, everybody who wanted to was invited to submit a photograph that represented their lived experience of changing from a active, engaged community life to this homebound life. And those photographs were so informative. Right? And then there's the video development and so on. So that, that words are just one form of communication. And when you're dealing with diverse communities, sometimes our words don't translate our experience well from our community where we talk with each other and we all understand each other's experience. And then we're talking to people who've never had that experience. And we're using the same words, but we don't mean the same thing. And so when you use multiple ways of expressing things, you get a greater depth of understanding. And I think, Melinda had some very specific and concrete ideas, like the cards. That's not words, that's cards that say, "Oh, this is how I'm feeling about this." I think that diversity in communication can really enrich the research and also enrich your research outputs, because that's something that Alejandra and I, between us, the research outputs have taken many, many different formats, and they're not all about words.
Yeah, I particularly like the videos that you, and we could also provide the links to those videos in the resources that we'll share after the series.
Thank you. I will take on Tony's comments on nutrition. And yes, I agree, Tony, and also sunlight, etc. All these things are so important. There is a program that is called Meals on Wheels. That have been supporting Australians as well. Obviously, I get your points about the type of nutrition that will be that will be helpful for Hmong people and for everyone as well. And those kind of ideas, those are our seminal ideas that could take us into several sub-projects to try to understand how can we improve the quality of life, health status, etc. So that's something that we could take further in the future. So thank you for sharing that information.
Thanks, Alejandra. And Melinda, I see your hand is up.
Yeah, well, I want to explain a bit more about the cards. They're really good for meetings and communication. This is the way they can talk. So these are very important in meetings, and it could be anything like a group, I just think, and also the pictures have to match the writing. You just make sure that actually is the saying what the writing what has to be visualized.
Thank you. Thanks, Melinda. If we don't have any other comments or questions from the audience, I'm happy to close the session. Does anyone else want to add a question or a comment before we close the webinar and move on to the last few slides around what's coming up next week?
We've scared everyone off. Oh, Tony's still.
Tony, you'll have to put it in the chat because we can't unmute. It's a webinar. I see one of the comments is, yeah, so just GPs visiting at home and getting enough funding for that. So Tony, why don't you send us your questions and I can forward them to our speakers. I would really like to thank our speakers today, Melinda, Penelope, and Alejandra. There was fantastic presentations and there's really some great work happening out there. Melinda, I loved your tips, really direct, and I think that's really going to help researchers understand how to better engage with people with intellectual disability and to just do it, not be afraid to go into that. And with Penelope and Alejandra, thank you so much for your presentation. And it's actually really great to see all the impact it's had and the way that you've engaged, how it's impacted the work and the sector and the field. That's what I'm trying to say. I'm going to end the session there. Next week, we are going to explore engaging with culturally and linguistically diverse communities. So we'll hear from the MCCSA, which is the Multicultural Communities Council of South Australia. George Gazounis is going to come tell us a bit more about the work that they do. And similar to what CODA presented last week, they also have a fee-for-service matching program where they actually match researchers to different groups. So stay tuned for that presentation. We have a CCI masterclass. So if you want to learn more about engaging consumers and community in your research, we do a full day masterclass, 9:30 to 2:30 at SAMRI. And we explore different modules. Penelope has been very involved in the development of this masterclass, so we thank you. The QR code is there. We offer free registration for 20 consumers or consumer reps, and then 20 registrations for researchers. So it's a day where we learn with each other and from each other. And finally, if you want to stay connected to HTSA's activities, we have a monthly newsletter, we have different networks, and we have all of our past Spotlight series on the website. So thank you again to our speakers, and I hope we see many of you next week at the week 3 of the Spotlight series on engaging people of diverse demographics. So thank you very much.